60 people subscribed, but there are now 63 people attending, so people will drop in later, I think. Yeah, we started to organize the webinars in the period that we were all unable to work, and we sat at home and we had time to do other things as treating people. So, and it was the same for me. So I had a lot of time to think and study and do the things that I always wanted to do. And one of the things that I always wanted to do is make a publication about my thoughts about plagiocephaly, because I'm working on this topic for many years, and I try to read as much as I can about the topic. And every time I see very interesting articles, but there's always a thing that was missing. So I thought it was maybe a good idea to put it on paper. So what I did, so I made a publication and I sent it to a journal, and it is now in the review time, so it will be reviewed. It is already reviewed, but will be other people also will read it, and maybe I have to change some things, and then it will be published later. So you will have a notification on your in your mailbox when it is ready to read it. And the webinar that I do this evening is a little bit the content of the article. And it's also a little bit the content of what I do in the pediatric course. So many of you attended already a course with me, so it may be a little bit of repetition. And I collected some things, so also for you, maybe it is also for you interesting. So there is a possibility to use the chat and ask questions, but when you are teaching, it's always hard to look at the chat and see if there is a question. So what I want you to do is please keep your questions for the end, and then I will take a look at the chat, and when there are necessary questions, I will respond. So plagiocephaly and osteopathy, what is exactly plagiocephaly? It is characterized by an asymmetrical distortion of the skull. And there is already a question, so I will take a look if this is a necessary question. Let me see. Oh, you can't hear? So I think everybody can hear me. But when you have a problem with your own microphone or your boxes, then I can't do anything for you. So when you look at the types of plagiocephaly, you can say there are two different types: the Synostotic Plagiocephaly, which is, let's say, the structural type. It is caused by the closure or the absence of sutures. And mainly it is, mostly it is in combination with other problems, and in many cases is the part of a syndrome. We will see a little bit about that later. And then we have the non-synostotic plagiocephaly, and the most common name is deformational plagiocephaly. And this is the functional type of plagiocephaly. And it is caused by external forces. So the structural type is caused by changes in the ossification of the skull. And here we see that the cause are external forces. It is mostly not present at birth and mostly develops in the second month. And there are pre- and postnatal factors that are important in the onset of this non-synostotic deformational plagiocephaly. What is exactly a normal skull? And when you say this is an abnormal skull, you have to know what a normal skull is. And this was described by Magoun in his book, The Osteopathy in the Cranial Field. There is a code. You take the white, and you multiply by 100, and then you take one, you divide it to the length, and then you have this, these nodes. And then we have the Mesocephalic, which is the average skull. So this is, you could say, this is the normal skull. Then we have the Brachycephalic skull, which is what we could say the flexion type. And this is from the work of Isatel and Christian de France, the Tressat. And this is the extension type. And so this is the Dolichocephalic. And these are all variations of a normal skull. So this is not abnormal when you see this. And I think as an osteopath, it's good to know, and maybe you use not flexion and extension, but better to use Brachycephaly, Dolichocephaly, and when you say in between, the average skull is Mesocephalic. Okay, then we have the Cranio-synostosis. What we could say, this is the structural type. Here you see a normal skull, and then you see all the variations when there is an absence or an early closure of the sutures. Here you see when the form when the sagittal suture closes. Here the trigonocephaly, you see when the metopic suture closes. Here you see the bilateral synostosis of the coronal sutures. Here you see one side of the coronal suture. Here you see the one side of the lumboid suture. And you get all kinds of variations. And this is the non-synostotical plagiocephaly. And this is not caused by closure or absence of sutures. This is by external forces. And this is mainly the form that is seen in our practice. So when you look at cranio-synostosis, you have the structural cranio-synostosis. You have a primary form and a secondary form. Primary form is very sporadic. It's mostly in combination with other defects, limb defects or other defects, and it is mostly a part of a syndrome. For example, the Cruzon syndrome and the upper and the Pfeiffer syndrome are syndromes where you see cranio-synostosis. And of course, this is not something for the osteopath to treat as a primary. We are not a primary discipline to treat this. Maybe we can help these children, and sometimes they have to be operated because the cranio-synostosis is limiting the development of the brain, and so they do operations. And maybe we can add a little bit, help a little bit, but this is not, osteopathy is not a primary form. This is coming from the book of Magoun. This is the closure of the sagittal suture, and then you have the scaphocephaly, the ship. It's like a boat, a ship, skull. This is the tower skull, the oxycephaly, when the skull is growing into in the cranial direction. And this is a Synostotic Plagiocephaly. So this is caused by an absence of or an early closure of the coronal and the lambdoid suture. And what is specific for this synostotic form is that the flat side on the posterior and the anterior are on the same side. So when you look from the top to the skull, you will see a flat side on the frontal bone, and you will see a flat side on the occipital bone, and this is caused by the closure. So this is very specific, and later we will see in the non-synostotic form that it is a different kind of form. What can we say about the incidence of the synostotic and the non-synostotic skull deformations? The incidence of the synostotic is 1 out of 1,500 births, and 75% is related to a syndrome. The synostotic, non-synostotic form, the deformational plagiocephaly, has a much higher incidence. We can say that 1/5 of the children have a light or a more severe form of plagiocephaly. And I will go into why this is occurring more and more. So what is the definition of a non-synostotic deformational plagiocephaly? It is an altered cranial shape at the age of 6 weeks, when the molding process of the birth is over, without ossification chains. So you can't say directly after birth this is a deformational plagiocephaly, because it can still be the molding process of the birth. So I think for you as an osteopath who works with children, this is a good thing to know. This is the definition of Leonardson. When you want to take a look at the references, I added all the references. About the etiology, there is no consistency. There are many reviews. The book made a systemic review, and then you can see there is not a consistency about etiology. There is no risk factor that is uniformly considered as dominant. The only thing that we can say is that there are external forces that are responsible for the deformation. So this is from the paper of the book. It's a rather recent paper, and so they looked at children. They looked at all the papers written about plagiocephaly. They found 22 studies, and they did a systemic review, and then they looked at biological infant factors, obstetric factors, infant care practices, lifestyle of of parents, and socio-demographic factors. And then you can see there are a few risk factors that are a little bit higher. For example, male gender. So you see it more in boys than in girls. In 16 of the 22 studies, it is mentioned. So in 72%. A torticollis, a limited head rotation, or a head rotation asymmetry. A preferred head position was also in, torticollis in 45% of the cases, a preferred head position in 37. There was an indication that in first burst there was a little bit more higher incidence. And a thing that was really interesting was the supine sleep position. And I think we all know that since the 90s, we have the prevention of the sudden death infant syndrome. And so the children can't sleep on the side or on the belly. They must sleep on the back. And we see that in many studies, this was found as an important risk factor. So when you summarized it, you can say, okay, male gender, supine sleeping position, limited neck rotations, preference in head position, so the head is always turned to one side or more in extension. It seems to be a little bit more in the firstborn child, and a lack of tummy time. So the child is not placed on the abdomen or does not play on the abdomen for the little bit older children. Then we have other postnatal factors. Again, the preferred posture during sleep, bottle feeding, always in the same position during body feeding, always in the same position during the change of the diaper, so always to the light, the window where the light comes from, always the head on the same side of the chest of the mother, and not playing on the abdominal, so not on the abdomen, not laying on the abdomen. And there seems to be also a slow motoric development, but there are also studies that say that this slow motoric development is caused by the plagiocephaly, so it is a comorbidity. So when we look at the etiology and the risk cluster, there is not a consensus so much, but there is more robust consensus about pathophysiology. So how does it develop? So first of all, what we can say, it is that when we look at all the children, and this is a Dutch physiotherapist, a PhD, who studied a lot the plagiocephaly, and he studied a lot of children, and he did not find a deformation at birth. But he saw that in most cases, the development is at the age of 2 months. So the conclusion was there must be external factors that have influence on the onset of deformational plagiocephaly. So DP is deformational plagiocephaly. And all the studies agree that it must be external factors. And one of the main is the gravity. So when you lay on your back and you're placed on the surface, it is the gravity that is the main factor that is influencing the deformation. And since the 19th, we have the sudden death infant syndrome campaign, where sleep, a prevention campaign, I must say, where children must sleep on the back, and then we see an increase of the incidence of this. So lack of tummy time, also car sits. The car sits also influence the development of the plagiocephaly. And another very important factor is the altered upper neck mobility in combination with the supine sleeping position. When we look at the classification, there are 3 classifications frequently used in the literature, and I think we also should adapt this in osteopathy. It is, the first of one is of Sergueef, which is an osteopath, and 2 others are more from classical medicine, Captier and Argenta. I will go over them in the next phase. So, first of all, published in 2006, the paper of Sergueef, who did a lot of work in the cranial field, and divided plagiocephaly in 5 types. And I think, you know, in literature, this is not so frequently used, but I think it's a good thing to have in your mind as an osteopath, because, as he said, where you have to look for the possible causes of the development of plagiocephaly. The first type was the positional and pregnancy related plagiocephaly. And the plagiocephaly is a result of a chronic asymmetry of the intrauterine position. The only thing we can say is that at birth, most of the plagiocephalies are not present. Of course, the forces that are influence the skull during pregnancy and during the position of the pregnancy during the so in the birth canal will also be present at later in time. So it can be one of the causes. Then we have the deformational plagiocephaly, and this refers to the forces pre and postpartum, peripartum, which produce the cranial asymmetry. So here the delivery has influence on the onset of plagiocephaly. Then we have the postural plagiocephaly, where the plagiocephaly is a result of the chronic asymmetry in the postpartum resting posture of the child. Then we have the compensational plagiocephaly, where the plagiocephaly is a result of a deformation in another area of the body. It can be the pelvis, it can be a fracture of the clavicle, it can be the diaphragm, it can be the thorax. And the 5th form, you have the ocular plagiocephaly, when it is associated with strabismus. And of course, we know that most children at birth, the eye coordination is so bad, they all have strabismus. So this only can develop in a later stage of the development. Then we have the Argenta classification. This is a classification that is published in 2004, and it is used by many people, and it is also tested by Branch in 2015. And it is a very useful tool, and I think also for osteopaths it's a very useful tool to use. And you will see there are different types. In the first type, you have no asymmetry of the ears. You'll see that the ears are equal. There is only an asymmetry of the occiput. And in severe forms, also the temporal bone can be influenced. There is no change of the forehead. There is no temporal bulging. There is no vertical elongation of the skull. So this is a type that you often see in your practice. The second form is a little bit more severe. So you see that the central skull and the cranial base are affected. So as an osteopath, here you could say only the occiput is influenced. Here you could say that the sino-basilar synchondrosis and the central skull and maybe the membranes are also influenced. There is a displacement of the ear. There is no influence of the anterior portion of the head. You have a symmetry of the forehead. There is no facial asymmetry. There is no decompensational deformation. And only the occiput, the cranial base, and the midcranial fossa are affected. We go a little bit further, and then we come to the Argenta Type III. And in the Argenta Type III, you see that the deformation is mainly caused by the sternocleidoid mastoid muscle. And you see that there is a fibrosis. I will go into that a little bit more deeply later. And this tension is influencing the form of the skull. So what you see is you see a flat side on one part of the skull of the occiput, a bulging on the other side. You see when you go to the other side of the frontal bone, you see a flatness on this side. A flatness on this side and a bulging on this side. So, and this is what we call the triad of the posterior cranial asymmetry. So a malposition of the ear, a malposition of the frontal bone, and a frontal bone asymmetry. And here you have a parallelogram shaped skull. So you see a flatness here, and you see a flatness here, you see a bulging here, and you see a bulging there. And when you remember the Synostotic Plagiocephaly, you could see that the flatness was on the same side, posterior and anterior. And here you see it is on the opposite side. There are no decompensational changes of the skull, and the face is symmetric. When you go a little bit, so it will be a little bit more severe, and you have the type 4, and you have the same changes, but here you see the change in the facial asymmetry, and you see an asymmetry not so much in the bone, but more in the fat in the face. So you see an asymmetry in the facial fat. And in the more severe cases, there will also be a little bit change in the bones. And then we have the type 5, and this is really the severe case. You will see the deformations, but you also see that there is a change in the diameters. And why? Because there is an attempt of the body to decompress the brain by bulging. So that you see that the cranium comes up a little bit, and the cranium goes a little bit to the side to make more space for the brain. And so, of course, this is really a very severe case, and this is the Argenta type 5. Then you have the posterior brachiocephaly. So these were plagiocephalies, because they were, this is asymmetric. And posterior brachiocephaly is not a plagiocephaly, it's a brachycephaly, but it is often mentioned also as a kind of non-synostotic form. And then you have three types. Type 1, this is this type. You see here that you have a flatness of the occiput. Here you have a flatness of the occiput, and you see a change in the bite on the posterior side. This is the type 2. And in the type 3, you see there is more expansion also at the level of the let's say the greater wing of the sphenoid, but you also see that the cranium goes up. So in type 1, it is like you have a ping pong ball. You push on the ping pong ball and you have the ping pong ball depression. So in type 1 here, this type, the lambdoid and the sagittal suture is influenced. The position of the ear, the forehead, and the face is normal. In type 2, you have a central depression of the posterior part of the skull, and you have a widening of the posterior aspect, and it is more pronounced flatness on the posterior side. And the type 3, you see the decompression of the brain. So you see that the body is trying to create space for the developing brain. And so you see changes. So this is the Argenta classification. And then we have the Captier classification. He is a French surgeon in the cranial field, and did a lot of studies in the field of non-synostotic plagiocephaly. And he found three forms: the fronto-occipital plagiocephaly, the FOP, then the occipital plagiocephaly, and the posterior brachycephaly. And you see them here. This is from his article. Here you see the fronto-occipital plagiocephaly. So there is a frontal change and an occipital change. This is the posterior brachycephaly, or the brachycephaly posterior en français, where you see that the flatness is on the back side, and this is the occipital plagiocephaly, where you see that there is only a flat side on one of the on the occiput, on one side. So what we can say is that the FOP, so the fronto-occipital plagiocephaly, oh, this is a mistake. I made a mistake. The occipital plagiocephaly, I will correct it in my script. I see there is a mistake. Is Argenta 1 and 2. Sorry for that. And the fronto-occipital plagiocephaly is the Argenta Type 3, 4, and 5. And the brachycephaly, posterior brachycephaly of Argenta is the same for Captier and for Argenta. So why do we use these two classifications? I use these two classifications because Captier is not only giving a classification for the form, he is also giving an indication for where to look. Where is the main pathophysiological factor that is influencing the plagiocephaly? And so what we can say is that for the fronto-occipital plagiocephaly, so this is the Argenta type 3, 4, and 5, is due to mostly a muscle hypertonia, or a sclerosis, fibrosis of the sternocleidoid mastoid muscle. The occipital plagiocephaly has more a neurogenic factor. So it is more caused by neurogenic factor. And the question is, what is the neurogenic factor? And I will go into that a little bit later. And the posterior brachiocephaly, it is due to the hypertonia of the suboccipital muscles. And for example, due to a trauma of the occipital cervical junction. And again, there is no synostosis. So here you see the study of Captier, and he studied 161 cases, and he found 98 cases of an FOP, 24 cases of an occipital plagiocephaly, and 39 cases of posterior brachycephaly. You know, I think this is not a very good indication, because of course he is a surgeon and he only sees severe cases. And in my opinion, the frontal occipital plagiocephaly is more severe as the only occipital plagiocephaly. So, and when you compare it, and I compare it to the patients that I see, I think it, in my practice, is the opposite. I see more occipital plagiocephaly and less fronto-occipital plagiocephalies, because these are a little bit more severe. I think when you Siri, close, shut your mouth. And I think when you look at posterior brachiocephaly, this is okay. I think this is a little bit the same in my practice. So, and when you look what he did, he looked at the forms. So here you see the fronto-occipital plagiocephaly. Here you see the occipital plagiocephaly, and here you see the posterior brachiocephaly. And he looked at all the factors: the pregnancy, the parity, if there were twins, the term, the delivery, if there was a breech presentation, if there was a difficult presentation, if it was a ventouse, a forceps, or there were cephalhematoma, if there was a caput succedaneum, and so on and so on. And when you look at the p-value, you know, there is hardly one that is really dominant. You can say, okay, maybe for this one, the first child, it is a little bit more in firstborn, and of course then when you only have one child, so one pregnancy and one child, and what you could say also here, there was no associated deformity, and when you compare it with the Synostotic form, you would find that most of them will have associated deformities. So this is really an indication that it must be a force from outside. There is was there a prolonged dorsal decubitus? Also here, in many cases, there was not. So yeah, it was a little bit remarkable to my opinion. Okay. So, what can we say about the pathophysiological factors in the onset of deformational plagiocephaly? In the onset of occipital plagiocephaly, so the Argenta Type I and II, it is mostly a neurogenic torticollis with an unilateral impaired function of the sternocleidoid muscle and the upper neck muscles. In the frontal occipital plagiocephaly, so let's say the Argenta Type III, IV, and V, it is mainly a myogenic torticollis due to a fibrosis of the sternocleidoid muscle. But it also can be a neurogenic torticollis. So what I will show you the indications, the percentages, and then you will see that in many cases it is myogenic. There is a myogenic torticollis, but in some cases there can be a neurogenic torticollis. In the case of a posterior brachiocephaly, there is no torticollis, but there is a neurogenic bilateral increase of the tone of the neck muscles. So I think for you as an osteopath, this is something very, very important. And that's why you have to know a little bit about the classifications, and you have to know a little bit about the two types of classifications. So this is also coming from the work of Captier. So what is the risk factor? Is muscle hypertonia. When it is unilateral, it can influence the lateral muscles of the neck, so the sternocleidoid muscle and the trapezius. It can be myogenic. Then you get a traction force on the skull base, and then you get a compression on the skull, and then you get the fronto-occipital plagiocephaly. When there is a neurogenic factor, a neurogenic facilitation of the muscle also increases in tone, and you get an asymmetric posture, which is also giving a compression of the back part of the skull, and this is influenced the occipital plagiocephaly. And when you have a bilateral form, you get bilateral contraction of the suboccipital muscles due to a neurogenic factor. You get a hyperextension, you get a limited rotation. The children are constantly in an extension position. You get a huge compression of the back part of the skull, and you have the posterior brachiocephaly. Interesting thing is to look at the comorbidity. So when you look at plagiocephaly, you see that, and you also find it in the literature, that the deformational plagiocephaly is not on its own. There are other symptoms in the children that are coming to see us. And so you can find it in more papers, the paper of Sargent of last year, but also Di Rocco also of last year. They describe this comorbidity. And one of the comorbidity is postural change, but also excessive crying, infant colics. So a lot of crying in infants, so in periods, that's what we call a colic. Gastrointestinal problems like reflux and constipation, respiratory and circulatory problems, the Harlequin syndrome, for example, when there is one side of the face is more red and one side of the face is more white due to the regulation of the autonomic nervous system of the circulation, but also an irregular respiration is also described by some of the authors. Feeding and drinking problems, irritability in combination with crying, sleeping problems, handling problems, they are all linked in some way to the deformational plagiocephaly. And then the question for me was, what is the cause of the neurogenic torticollis? Because when you look at Captier, he's talking about neurogenic torticollis. What is exactly this neurogenic torticollis? That was my first question. And my second question is there maybe a common factor that is responsible for the deformational plagiocephaly and the comorbidities? And my answer is yes. And my answer is it is the brainstem facilitation. And I work a long time already on this topic, and I find more and more evidence that this is really the case. So let's go a little bit back to the work of Denslow and Kor. They described the somatic dysfunctional model. And for them, the spinal cord was bombed by a facilitation nociceptive information, and this segment became facilitated and impaired the functioning of the segment. So this segment was influenced by nociceptive information or a restriction in movement, and was influencing the functioning of the segment. Professor Jenich, he worked together with Hollis King and Michael Patterson. They wrote an excellent book what I really can recommend, The Science and the Clinical Application of Manual Therapy. And Professor Jenich, he spent one chapter in analyzing the work of Denslow and Core. And what he said was that the model of them was right, what they observed was right, but you know the neurophysiological explanation was not completely correct. And he said this somatic dysfunction, what you say in osteopathy, somatic dysfunction, here you have the definition of Gutierrez. The somatic dysfunction is actually a peripheral and a central sensitization. So when you have somewhere in the body, you have a restriction in motion, or you have pain, or you have nociceptive stimulation from a tissue, this will cause locally a sensitization, but it also will influence a sensitization in the spinal cord and on different levels of the central nervous system. And this is what we call a peripheral and central sensitization. And this is really very, very well studied and confirmed in many studies. And when you see the somatic dysfunction, influences the sensitivity. There is somebody who is not muted. The sensitivity, it is influencing the muscle tone, it is influencing the muscle function, it is influencing the reflex activity, and it is influencing the autonomic function. And what we can say in general, in the case of a somatic dysfunction, the sensitivity is increased, the muscle tone is increased, but the muscle function is decreased. So a muscle is weaker in its force, is easier fatigue. So when you have a restriction in the neck at C5 or C6, but let's take C5, and you must work in the house, you will say, okay, my deltoides muscle has less force and is easier, is quicker, is there a muscle fatigue? And this can be caused by this somatic dysfunction. And the somatic dysfunction can be local, it can be regional, and it can be systemic. When you want to read something about the somatic dysfunction, I really can recommend this book, The 5 Osteopathic Models, where the somatic dysfunction is described. So here we have from Fryer a somatic dysfunction. So let's say you have a trauma, macro trauma or micro trauma, and for example in the spine, you will influence an intervertebral joint. You will have all kinds of reactions. This will influence the joint. You will have inflammations. You can have a tear of the disc. You can have a periarticular inflammation, and this all will influence the nociceptive, give a nociceptive activation. And this nociceptive activation will influence the sympathetic nervous system, will influence the tissues, will influence the elasticity of the connective tissue. It will influence the sensitivity of sensors. It will influence proprioceptive. So you will have another feeling of movement in this area. You're not, when you move, you don't move so well coordinated as before, and you will have a change in your motor functions. You will see that there is a change in the paraspinal muscles. So this is what we call a somatic dysfunction. And again, this is very well studied and confirmed by studies. So let's take this model and let's take this model at the level of the brainstem. And let's say, okay, when we can have a somatic dysfunction in the spinal cord, can we have a somatic dysfunction at the level of the brainstem? And my answer is yes, of course. Because when you have, for example, a baby, like this baby, who had a very traumatic birth, vacuum and damage of the skin, and you see the edema here, or you have a forceps delivery here in this child, and there was damage of the skull, damage of the skin, damage of the connective tissues, damage of the all the tissues of the upper neck, and so on. This will cause an afferent stimulation of the trigeminal nerve, of the vagus nerve, and the upper spinal nerves of the neck. This will facilitate this. This will facilitate brainstem nuclei and will lead to a peripheral and central sensitization. So the same process as what you have in the spinal cord, you can have it at the level of the brainstem. So you can have a peripheral and central sensitization. So when you look here in the upper neck, you will see that there is in the tissue, there is a sensitization. There is a sensitization of the, for example, of the ala major, the greater wing of the sphenoid, of the occiput, and so on. But also in the central nervous system. And the sensitization will influence the functioning of your brainstem. It will increase sensibility. So it means that when there is a facilitation and you touch, you put your hand on the skull, of course, the child will react because there is an increased sensibility in this area. But you will also influence the output of the brainstem. And when you look at the output of the brainstem, we have many muscles. I don't have the time to go over all the different muscles, but you know, there are many muscles, and you get an increase of the muscle tone. For example, the muscle tone of the sternocleidomastoid muscle, because this is innervated by the branchial nucleus, the ambiguous nucleus of the spinal nerve, the 11th accessory nerve, cranial nerve, and also the trapezius muscle. So, and this will influence the muscle tone, but also the muscle function. And again here, you will have an increase of muscle tone, but you will have a decrease of muscle function. And this is interesting for us when we test. We can also have a sensitization that influences the autonomic nervous system. And in the brain stem, we don't have sympathetic nervous system, but we have a parasympathetic nervous system. So what we see is that the sensitization is influenced the parasympathetic nuclei. And the parasympathetic nuclei, you know, this is another topic that I looked for this in many years, and I discussed this with Professor Neuhuber, and he confirmed this. That, you know, when you look at the parasympathetic nervous system in the brainstem in the situation of sensitization, you will see a different reaction of the different nuclei. And what you see is that the nuclei that are influencing the head, so the third, the ocular motor nerve, the facial nerve, and the glossopharyngeal nerve, their function increases. So you get more tears, you get more mucosa, you get more mucosa in the mouth and so on. But the function of the vagus nerve in the direction of the gastrointestinal system decreases. And I think this is a very important thing, because in the comorbidity, we see that in the deformational plagiocephaly, many of the children have reflux, have problems with colics, with constipation, diarrhea. And I think this might be one of the reasons, because there is a decreased function in the parasympathetic nervous system. So when we look at the somatic dysfunction in newborns, when you have a damage by a birth trauma, or when you are constantly with your head on one position in your bed, you will have a pressure, and at the end you will have some pain in the area, and this will cause facilitation. And when we look at the nuclei, there are many nuclei in the brainstem, and here you see on the left side in blue you have the sensoric nuclei. On the right side you say the motoric nuclei, and one nucleus is very important, because the main nociceptive information from the cranium is coming in the spinal nucleus of the trigeminal nerve. And certainly the paraspinal nucleus of the trigeminal is a very important hub. And when nociceptive information comes in here, it will directly influence the functioning of the ambiguous nucleus, dorsal-motor nucleus of the vagus nerve, and hypoglossus nervus, and accessory nucleus, for example. So when we look at the somatic dysfunction in newborns, we can say that there is an increased sensibility of the head, the face, and the upper neck. When you touch this, there is more sensibility. Parents tell you when they want to clean the ears, the nose, wash the hairs, the child is reacting, dressing and undressing. This is everything on the head, touching the head, is more sensitive because of this increased sensibility. Please don't say it is a compressed vagus nerve. It is bullshit. It is not a compressed vagus nerve. It is the facilitation. It is the sensitization. And it also influences the senses. So the eyes and the ears are also more sensitive. It means that the child is more sensitive for light. And when you come in the room and you close the door a little bit too loud, they are awake. The motor reflex is a little bit more activated. This is due to the increased sensibility. There is an increased muscle tone. It can be asymmetric by the sternocleidomastoid muscle or the trapezius, or it can be the upper neck muscles, where you get a dominant posture. You get an impaired muscle function, weakness, and an early fatigue of the muscles. And you get a changed autonomic function, an increase of tear production, an increase of mucus production, and a dysregulation of gastrointestinal system. And I think this is a very important thing, you get an increased reflex activity. Children have more reflexes than adults. I will go over these reflexes in a minute. So this is coming from the work of Golden, not the drawing. That's what I asked somebody to draw for me, because I didn't have time to make pictures in the Corona time. So this is a chart. So this is the function test in a baby of the sternocleidomastoid muscle. So what you do, you don't do it in the first 2 months, because there is a poor stability of the upper neck. So don't do it in the first 2 months, but normally the onset of the non-synostotic plagiocephaly is after 2 months, so it is not necessary to do it. It's better to do it a little bit later. So you put the child in a sitting position, and then you move it slightly backwards. You move it slightly backwards, and then you look at the position of the head. And normally the position of the head is symmetric. And when there is an impaired function of the sternocleidomastoid muscle, the head will make a side bending. And it will be in a side bending towards the affected sides. So it will bend, it will twist to the affected side during the test, not during the lying position. So keep that in your mind. It will side bend to the side where you, because of the fact that the muscle is not powerful enough to stabilize. Yeah, so it will be side bending toward the impaired side. Okay, then the reflexes. So I told you children have reflexes, more reflexes than we have, because in us the reflexes are inhibited. So I don't go over all the reflexes. There are people that are more specialized in this than I am. But I want to show you two types of reflexes that are important for me in this topic. And this is the survival at birth reflexes. This is the suckling reflexes. So when you put something in the mouth of the child, it starts to suck. The Moro reflex, when you bend a child backwards, it will extend the arms, and the rooting reflex. And what we see is that these reflexes are programmed in the brainstem. So they are very old reflexes, and they are very deep in the central nervous system in the brainstem. And they are already present at birth. That's why we call them survival at birth. And what we see in the children when there is a brainstem facilitation is that these reflexes are more vivid, they are more enhanced. It means that they are stronger. So it does not mean that the child is more hungry, that it had more, people tell you, okay, he wants to drink all the time, and you say, ho, this is not because the child is hungry. He's looking for the nipple all the time. No, he's not looking for the nipple. It is the reflex that is more vivid because of the facilitation. So it is very important to understand this, that this is not hunger. This is not because the child needs more milk. No, it is because of the facilitation. And I think it's very important, because when you don't listen to that and you give the child too much drink, you will cause other problems which also influence the behavior of the child. So this is important. The second thing is that children have postural reflexes, not directly at birth, but after a few months. And two postural reflexes are very important. The first one is the tonic labyrinthine reflex, and the second one is the asymmetric tonic neck reflex. And what you see is that these reflexes are more powerful, and they are more powerful due to the facilitation and the altered proprioceptive input from the upper neck, but also because of the fact that in many children the upper neck is restricted in its movement. So it means that there is a facilitation, but there is also a constant change proprioceptive information, and this is causing these reflexes. So this is the asymmetric tonic neck reflex. When you see when the child rotates to one side, you see an extension of the arm, extension of the leg, and you see flexion, and you see a side bending. So many children who have dysfunctions in the upper neck will have a brainstem facilitation, will have a more pronounced asymmetric tonic neck reflex. And this will even be stronger because of the upper neck restrictions, which are influencing the proprioceptive information that is influencing the brainstem. So in many cases, you will find the dominant asymmetric tonic neck reflex. And the other case, when the child is making an extension, so it's a bilateral movement, you come into the tonic labyrinthine reflexes. So this is something you see when the child is more laying on the back and the neck is in an occiput bilateral anterior position. And also this is due to facilitation, but not only facilitation, also a restriction of the upper neck. So the dominant posture is an important factor in the onset of deformational plagiocephaly. It's not primary, it's not primary in the skull, but it is brought into the skull. This is the definition of a dominant posture. Here you see the synonyms of the dominant posture, and here you see the incidence. And when you see the incidence, it's almost equal to the incidence of the non-synostotic plagiocephaly. So probably it is related. 40% of the children have a preferred site. There is an interesting study from Previc, already old study, but I think it's still very interesting because most children are in this position in the uterus of the mother. And it means that the right ear and the right vestibulum is anterior and the left vestibulum and the left ear is on the posterior side of the uterus. Because of the walking direction of the mother, because most of the time you don't walk backwards or sidewards, you walk forwards, this is like a rotation for the child, a rotation towards the right. And Previc said that most children have a rotation a little bit more to the right because of this position in the uterus. And I think he's right. I think this is a very interesting thing because this is also something that I observe in my clients. So let's come back to the Argenta types. So the fronto-occipital plagiocephaly. The fronto-occipital plagiocephaly. It's the Argenta Type III, Type IV, and Type V. In the study that I found from more studies, but Captier studied this very, very detailed. 60% of the children with these type had a congenital muscular torticollis. And a congenital muscular torticollis is a peripartum fibrosis of the sternocleidomastoid muscle. And this was in most cases. Sometimes it was only a tonus, there was no trophic change, but in most cases, in 60% of the cases, it was really a fibrosis of the sternocleidomastoid muscle. And so for you, when you test this child, you will see a head-tail test to the side where the muscle is impaired. And more and more osteopaths are also using sonography. And I think this is a very good thing because palpation, muscle testing in combination with sonography is the best assessment option. This is Sergueef who published this last year. So you do a palpation of the sternocleidomastoid muscle, you do the tilt test like I told you before, you bring the child a little bit backward and you look at the position of the head, and then when you have the possibility, you do a sonography. Is this important? Yes, it is important. This is a patient of mine, he's still seeing me, he is now 70 years old, and he came to see me because he was suicidal of his tinnitus. He had a very, very severe tinnitus. And he said, okay, you are the only treatment option because, you know, I don't want to live anymore because it was so severe. And I started to treat him, and he had a very, very, very severe fibrosis. You a little bit can see it here, fibrosis of the sternocleidoid muscle. You know, and I was treating him, and I was, you know, having a little bit of result, and a little bit. And at a certain moment, we had a very good result. And then he stepped into a flight simulator. And of course, the flight simulator, you know, it disturbed everything, and I had to start again. But now he's still seeing me, and 4 times a year, and he's functioning well. And I said, okay, can you bring me some photos of you? Because I'm interested. I'm interested to see the development, you know, and I think it is fantastic. Because here you see him at 6 months. And he has the fibrosis, but you know, you see the child. It is not a proper test, because it is a little bit side bending towards the left side, but you don't see the change. You don't see the change, and then you see that 2 years, and then you see the side bending towards the right side, and then at school age, your face starts to grow. And then you see the ears here are still low, and then you see a little bit later, you see the ears go up because of the development of the face. And here you see at the age of 11, you see the asymmetry is completely in the face. And it was due to a birth trauma. So you see here you see the fronto-occipital plagiocephaly is influenced in the form of the skull. He is here as a young man, 23 years old, and here you see him now at the age of 68. So, you know, I think when you have this type, you must be very, very aware that this can have a big consequence. And, you know, it happens to me a few times a year that I have to send people to the surgeon. You know, and of course, I don't like to send people to the surgeon, but you have to be aware that when there is a severe fibrosis, you are not able to treat it. You're not the primary form of treatment. You can support, of course, you can help after the operation. The treatment techniques are very, very good now. They are very small scars, and they do it with a scope. And they have 2 options. Either they do only the medial side, or only the lateral side, or both sides. And it can be very, very effective. Let's take a look at the others. Here you have the occipital plagiocephaly, Argenta Type I and Type II. These are caused by neurogenic torticollis. Here you see the flatness only on the occiput and a little bit on the temporal bone. And here you see the flatness on the occiput, temporal bone, you see a shift of the ear, and you know that the cranial base is affected, that the middle and the posterior cranial fossa are affected, and that the face is not affected. This is caused by a neurogenic torticollis. And now you know that this neurogenic torticollis is a facilitation of the muscles. And the facilitation of the muscle gives a posture, and facilitation gives a dominant reflex. So the children are in a dominant position, and this dominant reflex in this dominant position is causing, is this neurogenic torticollis, and is causing this form of plagiocephaly. The same for the posterior brachycephalic type 1, type 2, and type 3. It is due to the neurogenic stimulation bilaterally of the upper neck muscles. And of course, in this case, you see a dominant tonic labyrinthine reflex. So let's take a look. I made a schedule for you. When you have a damage or irritation of internal or external cranial structures or in the upper neck, you get a restriction in motion of the upper neck. This will give a somatic dysfunction of the brainstem and of the upper cervical medulla. It is a central and peripheral sensitization and can be symmetric and asymmetric. When it is symmetric, you will see a bilateral contraction, a bilateral increase of muscle tone of the upper neck muscles, which also will restrict the motion of the upper neck, will have a prolonged hyperextension due to the persisting tonic labyrinthine reflex, and this will lead to a deformation of the cranium. And in this case, it is mainly the posterior brachiocephaly. In the asymmetric form, it will give an unilateral increase of muscle tone of the sternocleidomastoid muscle, trapezius, and other neck muscles. It will give a persisting asymmetric tonic neck reflex, which will again also increase the restriction and increase the problem. This will give a prolonged side bending, ipsilateral side bending, and contralateral rotation. And this will also cause a deformation of the skull. And this will mainly be an occipital plagiocephaly, and some cases, not severe cases, of the fronto-occipital plagiocephaly. So, how do you assess it? Let's say there is a deformational plagiocephaly. The best thing is to make photos. You ask the parents to make photos from the side, from the front, the back, from the side, and from above. And you look, what is the type? Is it a fronto-occipital plagiocephaly, the type Argenta Type III, 4, and 5? Is it the occipital plagiocephaly, Argenta Type 1 or 3, or is it the posterior brachycephaly? Let's go to the fronto-occipital plagiocephaly. When there is a fibrosis of the sternocleidomastoid muscle, advise to go to the doctor and ask for a sonography. I mean, you can do it yourself, but when you feel fibrosis, you have to send them to further assessment, because this is very important. You can prevent a lot of problems. When there is no fibrosis, do the tail test, do the side bending test, and you test the muscle tone, you test the sensitivity of the head, the neck, and so on, and you test the reflexes. And then maybe you have indication to do some treatment. The same for the occipital plagiocephaly, do the tail test, look if there is a side bending, look for the reflexes, and of course this will be asymmetric and this will be symmetric. A very important thing is, and that's why I put it into red, is that the side of the torticollis is contralateral to the side of the flatness of the skull. So here you see a torticollis on the left. So this is you look from above. So this is left and this is right. Then you have this is a fronto-occipital plagiocephaly. So there is a sclerosis of the left sternocleidoid muscle. And this is really pulling on the membranes of the skull. And this is giving, and now you have to look at my head, is giving a side bending towards the left, but a rotation towards the right. Because in the upper neck, the side bending is always related to a contralateral rotation. And so the flatness will be on the other side. And the flatness is not only caused by the position of the head, it is also caused by the fact that the membranes are pulled by the sternocleidomastoid muscle that is pulling on the periosteum and is pulled on the intracranial membranes. So please keep this into your mind, that when you test this child will be in a tilt towards the left. So the man from before, he had the tilt towards the right side. Okay, so the treatment options. When there is a fronto-occipital plagiocephaly with a congenital sternocleidomastoid torticollis, supportive. To surgery, start early. The earlier you start after an operation, the more you are effective. You know, I always told my students, and I thought, okay, I have to wait 8 weeks after operation to start with treatment. Complete mistake. When you can, treat the day after, because when you treat the day after, you will have the less scar tissue. It is, I forgot to place the reference, but this is you will find it 2011 of both and Suzanne Chapelle. The occipital plagiocephaly, the posterior brachycephaly, and some cases, 40% of the cases of the frontal occipital plagiocephaly, look for the cause of the somatic dysfunction, and then use the model of Sergueef, and then treat what you find. It can be in the cranium, it can be in the upper neck, it can be caused by a position in the uterus, it can be the burst process, it can be fracture of the clavicle, it can be caused by the eyes, it can be all kinds of things. Be open and look where the cause is. And then it is very important for all forms that you treat the mobility of the upper neck. Maybe it is not the primary, but I think it's the priority. So when it is not the primary, it is certainly the priority. Because when you free the upper neck, you prevent the forces that are responsible for the onset of a deformational plagiocephaly. So that's why you have to treat the upper neck by very soft techniques. Positional technique have no, is no go, because when you position them in a position, you have to wait for 5 months. Because otherwise you put them in a reflex. So you have to wait for the inhibition of the central nervous system. It does not work. So what you have to do is a very, very light technique to mobilize and use the eggshell, and it is very, very effective. And I could not find any osteopathic study that said side effects. There are side effects with manipulation. That's why we don't do manipulation. The side effects that are due to manipulation are respiratory problems, because when you manipulate the upper neck, you influence the brainstem, and in the brainstem you have the respiratory nuclei that are influencing your respiration. So when you give a manipulation, you might influence respirations in children, and they get they hold their breath for a longer period. That's not the thing that you want to have. So don't manipulate. But there are no. I could not find any adverse events in immobilization technique. So it is completely safe as far as we know till now. So here you have again the model of Sergueef. Look for the pregnancy and all the things that influence the cranium in the pregnancy. Look at what influenced the delivery. Look at the postural. You will. This is a very important part, as you understood. And look at compensational plagiocephaly, because it can be caused by a pelvis problem or the ribs or a clavicle, and of course it also can be influenced by eyes. Then of course you have to treat the cranium. And the first thing you have to realize when you treat children, they are membranes. They have a lot of membranes, and that's why the membranous system is so important. So here you see the membranous system, and the membranous system with the falx, with the tentorium. So you have to work on the membranes. And there is an interesting study of Kostopoulos. You can take a look. Of course, it is cadaver tissue, but he could show that when you work with the cranium, you can influence the falx cerebri, for example. So there is evidence that over osteopathy, we can influence the membranes of the system. So many people think there is no evidence for cranial osteopathy. I completely disagree. There is, there is a chaos concerning the primary respiration. This will be another topic and another article that I wrote about that. But, concerning evidence of cranial treatment, there is a lot of evidence. And we can influence, and certainly in children, you can influence the dura, you can influence the tension lines in the dura. And of course, you really have to work on that. And of course, then work on the sutures and realize this is shortly after birth. There are no sutures. You have the fontanelles. The child has to form the sutures. After a few years, this is the skull. But this is the skull of a child. So when there is a brachiocephaly, posterior brachycephaly, or there is an influenced lambdoid suture or a influenced coronal suture, of course you have to work on that. And you work with very light techniques, but you mobilize the tension patterns that as an osteopath you can feel that are on the sutures. After you free the membranes, of course. And then we have synchondrosis. When you look at birth, look shortly before birth, this is the cranial base. This is the cranial base of a fetus. And we have synchondrosis, which is cartilage. And synchondrosis is the cartilage, like the cartilage of your rib and your sternum. And of course, you can breathe. Look at your Bechterew patients where the cartilage disappeared. He can't breathe anymore by moving the thorax, but you can breathe because you have a synchondrosis. And of course, in a synchondrosis, there is movement. There must be movement. Of course, you can have strain patterns. And you can understand now that pulling of a sternocleidoid muscle or a specific position will influence the mobility and strain patterns. So when we work as osteopath on the cranial base, we work on the strain patterns that are present in these synchondroses. Look at the occiput. There is before the age of 3 years, this is still mobile. So there is mobility between the lateral part and the lower squama. At the age of 6, till the age of 6, this is still mobile between the basilar part and the lateral part. So there is movement. Of course, later you have plasticity of the bone, but not movement like before these ages. That's why you have to start early. Don't wait. Start early. Free the strain patterns. The same for the sphenoid. This is the sphenoid, greater wing, the body, the lesser wing, the pterygoid plates. Till the age of 1 year, you have cartilage here. So there is cartilage here, and it means that the part of the greater wing is mobile against the body, and you have strain patterns that are influencing this synchondrosis. The same for the temporal bone. You have the mastoid part, the otic part, you have the squama. Till the age of 1 year, you have a synchondrosis here. And you can have strain patterns. So you have to work on, you have to know all the synchondroses, and you have to work on on the strain pattern that are present in the synchondroses. A lady that was very, very supportive for us is Rosaline Lalospo. And I really want to give her some credits, because she spent her life really working on craniums, and she did a lot of work. And unfortunately, she did not publish a lot in English language. And that's why she's hard to find when you go to PubMed and so on. But she wrote some excellent books. She had an excellent website that you can visit, also available in English. And she organizes courses. When you are interested, you can go to Paris, where she gives her education. And I found one slide on the internet, and here you see a child at 3 months. You can see it is really a fronto-occipital plagiocephaly, and then at 4.5 months and 1 year, you see the treatment result. And this is fantastic. It is not work by me. It is work by Rosaline Lalospo. And when you want to have more information, you can go to her website, what I really can recommend. The nice thing is she works a lot together with orofacial surgeons, and she has a lot of materials also in her books, which I really can recommend. So we can conclude now, and we can conclude that osteopathy is an effective treatment for deformational plagiocephaly. There are several studies that support it. Lessard, King. The Argenta classification and the Captier classification is useful in diagnosis and certainly in communication. I think as an osteopath, we have to be clearer in our communication, and when you work together with surgeons or general GPs and so on, it is good to say, okay, this is Argenta Type I, Argenta Type II, Argenta. So this is very interesting, I think, for us to do. I think it's a good assistant for our approach, because we can think about what possibly is the cause of the deformational plagiocephaly. And what we can conclude is that the fronto-occipital plagiocephaly is mostly caused by a myogenic torticollis. Can be fibrosis, and when it is fibrosis, osteopathy is not the primary treatment option. In some cases of fronto-occipital plagiocephaly, occipital plagiocephaly, or posterior brachycephaly, they are caused by somatic dysfunction of the upper neck and the cranial base. And the somatic dysfunction, which actually is a central and peripheral and or sensitization, increases the sensibility, increases the muscle tone, change the muscle force, enhance the reflexes, and disturb the autonomic parasympathetic regulation. So muscle tone, muscle weakness, and enhanced reflexes are the most important pathophysiological factors in the onset of deformational plagiocephaly. And the sensitization of the brainstem and the upper neck is mainly responsible for the comorbidity of deformational plagiocephaly. In cases of occipital plagiocephaly and posterior brachycephaly, and some cases of fronto-occipital plagiocephaly, osteopathy is indicated. I think this is also for medicine very important to know. So, what is the advice? Look for the cause of the somatic dysfunction, use the Sergueef model, free the upper neck, always with light techniques and so on, regulate the muscle tone, regulate the muscle function, and try to inhibit the reflexes. Work on the membranous system, work on the membranes, treat the sutures, You know, that many people are a little bit, you know, afraid about the structure, but you know, you have to, uh, don't forget the structure. Of course, the function is important, but don't forget the structure, because it's also very, very important in very young children. And Rosalind Cirilli is her credit, showed how important suture treatment is. Treat the synchondrosis, always with light techniques, use molding techniques, and yeah, be aware that you have critical dates. When you wait till the age of 8, 9, 10 years and you look at the occiput is one bone. When you wait till the age of, let's say, 17, 18, there is no synchondrosis, venous-basilar synchondrosis anymore. There is an ossification between the occiput and the sphenoid bone. So treat them early and check the child every time the child reaches a milestone. I have to be honest, you know, a mistake that I made was I treated the child and I say, okay, everything is okay now. Okay, bye-bye, stay healthy. And then 1 year later, I saw them back and I saw the Plagiocephaly, and I was looking in my dossier and saying, hey, did I miss something? No, I did not miss something. But the power lines are still in the system. And when the child is growing, is developing, then the power line pops up and influences the functioning and the structure. So every time when they start to sit, when they start to walk, when they, and so on, and they start to talk more, these are all milestones, and it's good to check them or let them make a photo and so on. But of course, a photo is only form, and you want to feel also the functioning as an osteopath. Okay, so thank you for your attention. I can now put on the chat and I can see if there are some questions. So I will respond in English, Karin. What do you think about helmet therapy? You know, also this was very much researched, and I think it is not effective. And in many countries it is used, but you know, I think it is the only thing that helmet therapy does is it brings the power lines a little bit in a bigger area. Yeah? So, you know, I would not recommend it directly, and it is also researched that it was not University of Twente did that. It was not researched so much, so good. It was researched, but it was not convincing. Yeah. Yeah, I was reading and answering. That's not a good thing. Yeah. Okay. So thank you. Okay, I want to add one thing, and maybe it's nice for you to know. You saw some pictures of the different forms. One of the things that I made is a poster for in the osteopathic practice, and I hope in 1 month it will be available for your practice. And I think it's very helpful, because then you have all the different forms, you have the reflexes, you have the ossifications, you have the things about when the fontanelles close and so on. So okay. Okay. Cut the umbilical cord after labor. I think it's good to wait till there is no pulsation anymore. But you have to check the website happybabycoach.be of Anja Kaars. look for her. She has all the answers about delivery. She's really a specialist in this. Yeah, on your account is the presentation. Not all the pictures because they are, I can't share them all, but the text you will have on your account. Yeah. Other people you know, when there is ossification, it has no, it makes no sense to do an operation. So I think it only makes sense when when there's still development and there is still growth process. Yeah. Okay, so people, I will close down and thank you for your attention and stay healthy and see you, hope to see you soon. Bye-bye.